My name is Ute Schneider-Milo, as she just said. I'm an osteopath from Cologne, Germany. And I feel very honored and still a little surprised to got invited to this conference. So I want to say thank you to the conference board to give me the chance to talk about my master thesis. And that was actually my job description for today, to present the results of my master thesis. And after this morning, fireworks of osteopathic knowledge, I still feel a little bit humbled, because this is not so much about this big research I did, it's really more about the process, what brought me here. So I hope, yeah. I never claimed being an expert in scientific research nor in holding lectures, but maybe at least I can say something about treating women osteopathically, and I assume that's why, or that's one of the reasons why I'm standing here. The last weeks I worked a lot on this presentation to make this talk, in spite of my German accent, at least half enjoyable for you. If some of you can take something home from it, I will feel very happy. So as an osteopath, I have to deal, like many of you too, with several frustrations. One of the frustrations is the difference between what we do in our daily practice, based on intuition, personal preference, and familiarity, and what is taught in osteopathic training, which should be, in today's scientific standard, highly objective. During my osteopathic training, beginning in 1997, I felt mostly inadequate, because I never got rid of the feeling that my teachers know secrets I will never know. Osteopathy seemed to me like a game whispered down the lane. Some old guy developed a technique and passed it on to another old guy. I was young. In 1997, there have been only 2 osteopathic books translated or written in German, and I felt utterly lost. Scientific research helped me a lot to get out of this situation, because it gave me the frame to understand how and why osteopathy might work. Through the methods of scientific research, I was suddenly able to think for myself, follow up statements myself, and finally could feel included in the group of people which call themselves osteopaths. So when I teach my students today, because I'm also a teacher at the German School of Osteopathy and in the subjects of clinical reasoning and gynecology, I try to be a little bit more cooperative than my teachers were. My students can challenge everything I'm saying, because I always tell them from where I've got my theoretical information or that particular technique. Today my presentation includes a small introduction of the background of clinical research, which you probably all might know. I will present my thesis, followed by some ideas of mine how to bring the results into our hands. So before I start with the science, I would like you to read this sentence, and just have it, let it sink in a bit. Before you judge others or claim any absolute truth, consider that you can see less than 1% of the electromagnetic and hear less than 1% of the acoustic spectrum. So 2 questions of osteopathic research. The first one is, does osteopathy work? And how does it work? The first question is about the effectiveness of osteopathy as a form of medicine, and is answered best by means of clinical research, meaning randomized controlled trials mostly. And as we heard today in Germany, we are somehow big in randomized controlled trials. I don't know how we got there. The second question is answered best by fundamental research, which Jane mentioned this morning, but this is not part of this presentation. So randomized controlled trials are used to assess the benefits and harms of interventions in healthcare. The first randomized controlled trial appeared in the British Medical Journal and was called Streptomycin Treatment of Pulmonary Tuberculosis in 1948. Today, the RCT is regarded as gold standard for a clinical trial. And to rate the quality of randomized controlled trials, different scales have been created by different organizations. Here's one which I just go shortly through. It's the PEDRO scale, probably everyone knows that. PEDRO meaning Physiotherapy Evidence Data Bank. And they say, for instance, that eligibility criteria, randomization, blinding, measures of outcome were obtained for more than 85% and so on are important if you want to do a trial like that. So with that in mind, I would like to read to you part of an interdisciplinary debate in the Journal of Bodywork and Movement Therapy from 2004. And it's Jan Dammerholt versus Ernst, as you can see. So Dammerholt, who is an American doctor of physical therapy, I don't know, you can look for him in PubMed. He does a lot of studies on manual therapies. And he said there are too many relevant variables in clinical practice which determine the effectiveness. Practically no modality or treatment approach was recently used by practitioners in healthcare could bear up against the strong rules of RCTs. That's relaxing, isn't it? But Edzard Ernst, probably everyone in England knows him by now, because he's the one who challenged Prince Charles, I heard recently, and got fat. He said clinical research often means making compromises and is fraught with challenges, obstacles, and problems. We probably all know that RCTs have some limitations. Until someone shows us conclusively a superior, less prone to bias tool, I would insist that there's presently no other. So, as you can see, there are challenges ahead for everyone who decides to write a scientific paper. So please stay with me to see how good or bad I handled it. My master thesis was called The Effectiveness of Osteopathic Treatment in Women with Endometriosis-Related Pain. Background. I saw this picture, I think, twice already today. I think you used it. 176 million women worldwide have endometriosis. This is 1 in 10 women during their reproductive years. Symptoms include chronic pelvic pain and difficulties getting pregnant, and therefore quality of life is drastically reduced. Often doctors don't realize that the symptoms come from endometriosis, and it comes to a delay of diagnosis of approximately 8 years. And these are facts which already make a cramp in my belly, because, you know, imagine you, for 8 years you have a pain in your belly and nobody really takes it serious or can tell you from where it comes from. So endometriosis occurs when cells of endometrium are found outside of the uterus. These misplaced cells, known as lesions, grow and bleed each month in response of hormonal changes. This results in inflammation and adhesions, and endometriosis lesions are most common on the ovaries, on the fallopian tubes, on the uterosacral ligaments, and the Douglas pouch. I forgot. So why some women develop endometriosis and others don't isn't clear. A conclusive diagnosis requires a laparoscopy. There is no known cure for endometriosis, and the medical guidelines recommend, depending on the life circumstances of each woman, the following: surgery, followed by hormones, followed by painkillers, or painkillers followed by hormones, followed by surgery. And it always matters whether the person still wants to have children or not. Treatment can have unwanted side effects, as you imagine. Lesions tend to come back after surgery or when the patient stops the hormone therapy. I had one woman coming into my praxis, and she was 35, And within the last 7 years, she had 5 laparoscopies. So you can imagine maybe a little bit how her tummy felt, or how the whole person felt. There's no known cure for endometriosis. The medical guidelines recommend, depending on the life circumstances, depending on the life circumstances of each woman, the following. Treatments can have. Where am I? That's there. So now, endometriosis is classified a benign gynecologic disorder, which for everyone who ever came across a woman, which I just said, with endometriosis-related pain, is a little cynical. Let me assure you that the suffering this disease can bring to a woman is enormous. So women are so desperate, now it comes, that there's even a market for this sort of t-shirts. And then I think it's already really bad. Finding a cure for endometriosis is priceless. So what does the complementary and alternative medicine recommend? The guidelines for the therapy of endometriosis. Is following. They recommend that the focus of rehabilitation after laparoscopy should be on the recovery of physical, psychological, and social well-being. There has been a large study by Sinai et al. In 2007, in which 1,160 women with endometriosis-related pain have been asked about their treatments, and 40.9% tried physical therapies, and 35% considered these treatments as helpful. So this was actually the fact which encouraged me to do this thesis in an area of endometriosis. My research question was...
Sorry, may I just ask you, is it 35% of the 40%?
Yes. My research question was, is it possible to decrease pelvic pain in women with endometriosis and increase their health-related quality of life through an osteopathic intervention? So, my study design, as I just learned from Michaela, I have a ridiculously small amount of 15 participants. And Michaela explained that you can actually look something up in the internet where they calculate for you which or how many participants.
Calculate you must do by yourself. Okay. You can look a minimal important difference for a questionnaire or for a visual analog scale or so. And with these values you can calculate the sample size.
Okay.
It's not 50.
Nee. It has been a within subject design, and the within subject design changes in the parameters in a phase without treatment are compared to those during a phase with treatment. That means the patients form their own control group. And to facilitate the comparison of results between studies, I followed a recommendation of the American Society for Reproductive Medicine to standardize inclusion and exclusion criteria as well as outcome measures in clinical trials regarding pelvic pain in order to do larger studies maybe afterwards. So my primary outcome measure was chronic pelvic pain measured by a visual analog scale. And the second measure, outcome measure, was quality of life measured with a validated disease-specific questionnaire EHP5. And why I picked that, I can explain a little bit later. No, I explain it now. That was a short version of an endometriosis health profile questionnaire. And I actually had the feeling that the compliance with my patients, even if they came to my praxis and got free osteopathic treatment, the compliance was going a little bit more down towards the end. So when you have a questionnaire which is like the normal quality of life questionnaire SF36 with a lot of items, sometimes people are not really into going through that. So the EHP5 was a short version of a longer one, and I was very happy to find that one. And this is how it looks. during the last 4 weeks, how often, because of your endometriosis, have you found it difficult to walk because of the pain, felt as though symptoms are ruining your life, had mood swings, felt others do not understand what you are going through, felt your appearance has been affected. I actually don't like it that I always have to turn my head towards this one, and I thought I can read that better, but I can't. So you have to deal with that.
You need glasses?
No! I need a bigger screen.
All right.
So during the last 4 weeks, how often, because of your endometriosis, have you been unable to carry out duties at work because of the pain, found it difficult to look after your children? It's also not better. Felt worried about having intercourse because of the pain, felt doctors think it's all in your mind, felt frustrated because treatment is not working, and felt depressed at the possibility of not having more children. So, my flow diagram of the progress, there was an enrollment phase, and 15 people are really not much, I admit that. Patients have been referred by gynecologists after reading advertisements in the newspaper and by word of mouth, which were actually the most. And it was quite disappointing to talk to the gynecologists about it because they were really not into it. Or the ones I talked about the study before I did the study. Afterwards, I did this talk in front of a group of surgeons, gynecologic surgeons, and they were actually very happy to hear that there were results about endometriosis which had nothing to do with operating or hormone therapy. So, you know that there was an enrollment phase with an inclusion and exclusion criteria got applied. One person was withdrawn from the study. I had a baseline phase of 8 weeks, and I did 2 points of measurement. And then I had a treatment phase of another 8 weeks where I've treated 4 times and had also 2 measurements. And then I did an analysis. All the 15 people completed the trial.
Did you do all the treatments?
Yes. That comes later in the discussion part. So my primary outcome measure was pain, and the test for significant differences in the progress of reported pain using repeated measures and analysis of variances. And as you can see, the result was significant change throughout the entire course with a p-value of 0.0007. Orange meaning the time of the waiting period, and turquoise meaning the time of the treatment period. But you also can see that this line is also quite large. So that also means that some women responded very well and some didn't at all. The second outcome measure, health-related quality of life. And that was because the results showed normal distribution, was tested with a non-parametrical test. And orange meaning again the time, the waiting time, and green and turquoise after the treatments. So it looks okay. Significant changes for question 1, 2, 4, 6, and 10. Question 11, which is the last one, showed the least change. And that was the one about the babies, whether you regret to not have any children anymore. So this one I just couldn't, or we maybe can't really influence. But the highly significant changes, that's just an example for the discussion, was question number 2, felt as though symptoms are ruling your life. And question number 10, felt frustrated because treatment is not working. And I did, question 11, felt depressed at the possibility of not having children, showed the least change. I analyzed these results further with a regression analysis. Michaela, you probably will understand what I did there. I did not make that now part of my presentation, but if anyone is particularly interested in that, come to me next time, we can talk about that. But that actually showed that the sense of control felt as though symptoms are ruling your life. That's actually the question of sense of control. And when we can reach that as osteopath, that gives the person something back for their life, I feel. So, obvious limitations. As you all probably figured out already, there are several flaws in my methodology. There has no been a randomization, no blinding. There was a selection bias. Only women with a basic interest in osteopathy got recruited. And within subject design, cannot make a statement whether osteopathy demonstrates better results in comparison to another form of treatment, because the control is limited. There was the examiner bias, such as positive expectations from my side, credibility of the therapist from the side of the patients, that all can influence results. And to avoid that, studies should be carried out multicentrically. That was your question. Meaning that more than one osteopath does the examination and the treatment. So my study group had been much too small to constitute a universal statement on the positive influence of osteopathy in women with endometriosis. And there has not been a follow-up, which I also highly recommend to do if you ever think about doing a randomized control trial. Just put it really, it's not much work, and you have a lot of information which you can get through it. Okay. And there have been things which have not been evaluated, like the treatment setting. The positive outcome of this trial can be explained by unspecific factors such as the length and regularity of treatments, the patient's characteristics, lifestyle, emotions, or spirituality have a large impact on health. We all know that. And last but not least, that was that, the skills of the therapist. So here we have to ask ourselves, are osteopaths who just finished their 5-year study course experienced enough to, as a therapist, to do a high-quality clinical trial? And we talked about that actually. We talked about making a larger study on it, and then we really thought, yeah, but how could we compare the therapists? How can we find out how much knowledge do they have in treating pelvic pain? So to make it clear, the conclusion. Osteopathy does not offer a cure for endometriosis, but could make the pain more manageable and can possibly stimulate an increase in some areas of health-related quality of life. And more research is needed. So these findings can still be important to some of us because we're confronted with patients suffering from endometriosis in our daily practice. And as I said, when I presented this study to surgeons, they actually were very delighted to hear that. They felt relieved, I had the feeling. I really was afraid to talk in front of 30 surgeons, and I thought, my God, they're going to dismantle me. But actually, they were very helpful and very happy, and they talked, and afterwards they even recommended women after laparoscopies to come to my practice. So that was the official ending of my thesis presentation, and now I would like to present to you what I have found out since then. So in real life, we can't say pain plus research equals happy organs. a very crucial factor is missing, and for us as osteopaths, it comes in the gestalt of this man. So now comes the second part of what has not been evaluated. And as some of you were probably already asking themselves, where's the osteopathy and all that? I didn't mention any technique yet, any osteopathic finding yet, so I have to explain it a little bit further. When I wrote my thesis, the thesis supervisors of the Vienna School of Osteopathy, where I wrote the thesis, told us that the osteopathic part of the thesis is not that important. So this part got a little neglected. All the more, I'm happy that I got a second chance to work on this part when I prepared for this talk. So they really said we just should focus on the research and on the model, and all the findings, they are anyway irrelevant because you can't prove it, and because there is really lack of inter-rater, whatever reliability. So I didn't do much on that. And this I have to recommend. If you are interested in the theoretical background of pluralism in medical research, I recommend to read articles from Kienle and Kiene. These are doctors, anthroposophic doctors, and they present a complete different view on research. And I really like that, and that helped me a lot, because they say therapy options should be evaluated by high quality research or documented by the practitioners through transparent, high quality case reports. And I think every one of us can do that in their practice. Whenever you have some really interesting client, just do that, write something to it, and collect it from routine patient care. Because as you saw before, there are so many factors which can't be measured. And case reports are maybe one area where we also can do research. So an advice from Patrick van Loon, founder of Cork, talked about him earlier. Does someone of you know him? No. He became the person charged for the MSc program at the Vienna School of Osteopathy only after I have done my research. And now he's actually the founder of CORP, meaning the Commission of Osteopathic Research, Practice and Promotion. And he has done some extraordinary work for research in osteopathy, but he's the real down-to-earth scientist. So he says, when carrying out our randomized controlled trials, it might be advisable to switch from a black box approach to an open box approach as much as possible. In an open box approach, the osteopath gives indication of justification of his diagnosis and therapeutical actions with the patients from the test group. Yeah, that's the open box approach, which I didn't do in my thesis. So, and treatments are only useful if they bring the patient to a new, better functional level. And this is really, again, how will you measure that? But I saw that this morning. We have so many tools which maybe can't be measured, but we actually feel that what's happening functionally in our body. So in Kushera said the most effective treatment plan is directed at the cause of the complaints and not at the symptoms, that everyone knows that. Find the lesion. Okay. Just a second. Because now actually really comes the second part. So, there are some theoretical explanations for pelvic pain. One of that is inflammation with its chemical and thermal processes, adhesions, which I'm going to talk about a little bit later, pressure of the endolesions on the surrounding nerve tissue, spasms of muscles, overstimulating of endometrial growth by increased inducement of local estrogen, and so on and so on. And actually, as osteopaths, we believe that we can treat some of these things. And I actually, when I started my thesis, I wanted to do a thesis on adhesions, because I thought that was cool somehow. Yeah.
I'm sorry to interrupt you, but I was very curious. Can I just ask you, what do you actually think is happening with,
What I think is
with
happening.
an endometrial lesion? Is it that the lesion actually is enlarging periodically, and that is what causes the pain? Is that?
That's one of this overstimulating of endometrial growth by increased inducement of local estrogen. Then it leads in our cycle. It grows and then it bleeds and then it grows and it bleeds. That's one of the reasons. But I think all of the reasons of it can be part. Yeah. Yeah, I wanted to do something on lesions. And then I talked with my thesis supervisor about it, and they said, forget it, because you will never, on a living human being, can prove anything, or there is actually also no known ultrasound, X-ray, whatever machine which can actually do something, which would be unbelievably costly. But I can show you an example for a fundamental research study in the area of visceral adhesion. And now you can't really see that because this is the belly of a little rat. So rats have been operated to create visceral scar tissues, then being treated with visceral mobilization. After that, they got killed to examine whether the lesions have disappeared. And they had a control group, you asked that yesterday, which rats got operated and not being treated. And they actually, they had a look straight after the massage. They killed them and they saw that the adhesions were already gone, and they actually were there for 2 weeks or so before. So, because it's a little rat, this might be a case for your own inner ethic committee. But we have to admit that these results can be useful for at least our theoretical background.
Do we have to kill the women between?
I think it's good that we can't really see what's happening there.
But you know what they say in the paper? They say, have a look at the relaxed little feet from the rat, because the rat is actually really happy there. You know, they relax and they got treated without anesthetics or so. They like it. That's the stomach. Yeah, it's on the back, and this is the stomach. You are happy that we don't.
Is this osteopathic work?
It was manual therapy. And you can look it up at Move et al. I didn't bring it. So my study did not provide a set treatment for women with endometriosis-related pain, because this contradicts some of osteopathic principles. That's what Michaela said. How did you call it? It was always dependent.
Test
dependent. That was a good word. Before I began treatment, I collected references for osteopathic tests and techniques in the area of pelvic pain. The first treatment consisted of a complete full body checkup with a special focus on the pelvis. Every region was tested and examined globally, and in the case of existing abnormalities was then tested locally. During each treatment after, detected dysfunctions were retested and were necessary given further or complementary treatment. So that's what I did. And I didn't list, like Michaela did, I didn't list the osteopathic findings in my trial. So I regret that today. And now I just can tell you from my own personal notes what I have found. Almost every woman had a sacrum which didn't feel normal. there were some restrictions in the fossa iliaca, in the uterus and the Douglas pouch. I mentioned that before, that most of the lesions were around the uterus, the Douglas pouch, the ovaries. The small intestines felt also a bit strange, because there might be the theory that there might be a ptosis due to deep infiltrating endolesions. And one of my teachers in osteopathy, Caroline Stone, probably some of you know her, who did a lot of work with gynecology, she recommended that you always have to treat the small intestines when you treat women with endometriosis. And I wrote her an email before I came here, but she didn't reply. And I said, Caroline, give me some more answers of why. But didn't hear from her yet. She's in Australia.
In Australia.
No, she moved to New Zealand recently.
Really?
Oh, then maybe I have
She
to.
divorced.
Maybe when I have the wrong episode. So thoracolumbar junction and the cerviothoracal junction and the cranial membranes and the symphysis spinobasilaris. So these were all areas which I frequently found osteopathic dysfunctions. This is all I can say now. So here's again something from Kuchera and Kuchera, because that's a great sample I find for protocols for enhancing homeostatic responses, what we want to do in our practical a little bit. And he said that you can either treat the sympathetic model, or you can treat respiratory, circulatory, or parasympathetic. And I chose some techniques in order to address every part of that. So for me, the beauty in osteopathic treatment lies in the variety of approaches, as you can see here. And you can treat the whole through its part with very precise and focused techniques. But you also can treat the parts through its whole with more general techniques. And before we start with some practical work, I would like to thank you for your attention. I think you were amazing, because nobody left the room and nobody got tired in the afternoon. I really thank you from the bottom of my heart. Thank the conference board for having me here. And yeah, you ready for questions? Huh? Yes.
Any questions? Can I say one sentence?
Yes.
You've done a great research. I think for such a within subject design, 15 patients are enough. And yes, and your supervisor, I cannot understand that he doesn't would like to have any osteopathic findings in here there, and the statistics for the primary outcome parameter don't say nothing with the analysis of variances. You could not see, is there a difference between the waiting time and the intervention time. You have to calculate the difference waiting time and compare it with the difference of intervention time. And a variance of analysis does that not do.
Aha. I have to talk to my statistician about this.
That they say to you, do not make osteopathic solutions, and have here a test where you have only such a little practice. Yes, it's not understandable.
They have not been osteopaths, our supervisors. They have been social science, whatever, doctors, and they were not really interested. And they said, because you anyway can't prove osteopathy.
Yes, and they are not interested in medical research.
But that also changed after I
When you will publish it, I make the statistic new.
Oh.
Yeah? Give me the Excel.
Wow, I would have
Excellent,
never dared
and
to
I
ask you. I
didn't
thought
do
about,
one.
oh, I would like to ask you, but then I thought, oh no, she's so busy. She will have
No, I make a
right.
new one.
Thank you.
There's a question at the back.
Sorry, can I ask, were the treatments given at the same time for the month for the women?
That's a very good question. In endometriosis, it's really difficult with the cycle because the women don't have a 28-day cycle. Some of them bleed throughout the whole 28 days. Some of them don't really or have this sort of
So could one, for example,
No, I'm not finished. I'm not finished. And I found with Baral, he did a recommendation. He said in the first 2 weeks of a women's cycle, you could treat actually on the particular part of the body, and in the second phase or in the second 14 days, you should do something more general to open up the lymph system to get a little bit fluid movement through the body.
would it be, for example, possible to take blood tests of hormonal changes to see if there is any kind of pattern underlying?
No, I think the hormonal changes, it's the local estrogen. You know, it's actually the local tissue hormones which do something on endometriosis. You can't really, that's otherwise they would diagnose it with blood tests. And they only diagnose it with laparoscopy. Yeah.
As part of your osteopathic management, did you consider any dietary recommendations to these women?
I didn't. I considered that, and I know about it, but it was not part of my study. Yeah, but it should be no red meat, no milk products. There are some things you can actually take, antioxidants and stuff, which also change something.
You had two statistically relevant questions, which was number 2 was how people felt about the pain level.
Yeah. Not about the pain level,
well,
about quality of life.
Yeah, the quality of their life. So was their quality of life improved because they felt they were managing the condition by getting osteopathic treatment? Or did they feel it was a better quality of life because the pain level was diminished?
That's a very good question. Actually, the two things I used as an example, the question number 2 was more because they had the feeling they could do something themselves. That's what I felt too. But other results from, you know, you were not able to walk because of your pain, or you couldn't go to work because of your pain, they were actually more related towards the pain.
There was quite a lot of variability between people who responded and people who didn't respond at all. Did you have any feeling as to what made a difference in individual patients contributing to that?
What's the question?
Why did some people respond very well and some people didn't?
I just noticed it myself, and since I did this study, I actually treated a lot of women with endometriosis, and I really see every woman is so different. Every tissue feels completely different, every story is completely different, because it's really, they all have a long story of disease, and I really couldn't say whether there is a red thread, roter Faden?
Yeah.
Like a you know, like some line, yeah, like a line which every woman have. I can't say it.
What are your insights? What are your feelings or suspicions as to why endometriosis is happening? You must be thinking about that side of it. Why should it happen?
I'm thinking about that my whole life, why disease happens, but I actually really think it's always a mixed bag, and I would never say it comes from abuse, or it comes from the woman doesn't feel good in her pelvis, or whatever. I would never dare to say something like that. I think it's always a bio-psychosocial, complexity. And I read so many research on the causes, and they can't say it, they can't tell. It comes from retrograde menstruation, that's why some women have it and some others don't, they really can't say. And there is a genetic aspect in it, but
Okay, no more questions?
Surely, you say that if it's coming from retrograde menstruation,
that's one of the reasons.
Has to be something which is tied up with the pelvic mechanics in the first place.
It's true.
So therefore, we treat all the babies, we end up with women
But,
without
some have retrograde menstruation and some others don't. But anatomically, it could be possible that endometrial tissue gets out of these areas and not just through the cervix. But this is only, they say this is only one reason.
You sure it's not embryologic, that there's some embryological stress in the organogenesis when you reproduce?
As I said, it's probably one of the things, but I would never dare to say that's never.
If you did it again, you could also add the question of whether they were breastfed. Because breastfeeding stimulates the immune system similar to lymphocytes, bacteria, which would be very important.
I think every bit of a healthy lifestyle would include, but this is the danger, you know, because I know some people who do everything right in their life and they have been breastfed and they're happy and they still develop cancer. So, you know, I find it very arrogant, from some of us, you know, to say we know it comes from there or it comes from there, because I mean life is so much bigger than our thinking. So that's the first thing.
You made the point that, I mean, I don't know whether you think it's a very difficult topic to take, but you made the point that every single woman with endometriosis is different. But that is our difficulty with research, because every single patient that comes into our practice is unique.
Absolutely.
Every single treatment is unique. Every osteopath is unique, and it's the dynamics between all of that.
Yeah. And
how can we ever quantify? I mean, I know it's perhaps throwing the devil's advocate.
Yeah.
Then said about the case histories, and those sort of. Do you feel
exactly.
that that's a better way of doing it?
Yeah.
That we could actually quantify that.
And if I have time in the future, I want to do more with case studies.
Because we could all do that, couldn't we?
Yeah.
Last question there.
When it comes to treatment intent, initially you said that you
Say that again.
When it comes to your treatment intent, initially you said that you was very interested with adhesions.
Yeah.
I think Caroline works pretty much on that route as well.
Yeah.
Here you show us 3 different possible treatment modalities.
Yeah.
How do you select the treatment modality for your patient? Is it random, or do you go by intuition?
Intuition. I teach clinical reasoning, and I really looked into that, and I found out, you know, what therapists do in their daily practice is the more experienced you are, the more you do it on intuition. You know, we don't do it then anymore, hypothetical, deductive, or what we actually learn. We really do it by intuition.
So you'd select from all of those treatment models depending on what you felt was required.
Yeah, because I have the immediate feedback. You know, I see how the woman looks and how they feel and how the environment is and how I feel.
Part of that's pattern recognition as well.
Exactly, pattern recognition. That's what we do.
Good. Thank you very much.
Moving on to the practical. No, I don't. The practical is not so long.
One more question?
One more question.
Just how long ago was
You can do the statement in the end, that would be good. I trust you.
How long ago was this study done?
I started in 2009 and finished in the talked about it in 2008.
I talked to the gynecologist recently, and it may be because of the ultrasound facilities that are now available, but he says he no longer does laparoscopies at all because the ultrasound is improved to
Yeah,
the extent
yeah,
that you don't need to do it.
yeah.
And he also said because every time you do that, you create adhesions.
Absolutely. Yeah. You know, this is what I also experienced. All the women with the laparoscopies, they are so proud of their little scars. But when I touch the scar of a belly button, and it's freaking me out. I'm serious, you know, there is nothing like a little scar. Really, you can't see it maybe, you know, but if you feel it, it's like, yeah. But there's also research that they want to diagnose endometriosis in futures by biopsy, because they also found some prostaglandin or histamine or something like that, which can actually show you that there is probably an endometriosis. So that's what's going to probably happen in the next 10 years.
Okay, mine's a... Yeah, it's just a happy ending story if it's a one-off, so you can read nothing really from it. But you talked about psychosocial issues, and some friends of mine, both osteopaths, wife has endometriosis, and she's had years of fertility treatment and many laparoscopies, and has finally had to come to the conclusion that babies are not for us. And they both decided we will focus now on our careers. And 1 year down the line, she got pregnant.
Yeah. Yeah.
So even with the endometriosis,
yeah. Yeah. There was something. There was some great thing, you know, because endometriosis really does something to the infertility, or to not able being pregnant even if you don't have adhesions, because it changes some chemicals inside your
But you know what Dawn is saying about adrenaline, oxytocin, so I think this woman, she finally gave up. She didn't want to control, and I want babies, less adrenaline, more oxytocin, and also, what do you say, what's the other hormone starts with P? Progesterone, because progesterone, that's what we need, and there's also an antagonistic function with adrenaline. So I think less adrenaline also for this woman. They're very stressed.
Yeah, but I have now a lot of women with Kinderwunsch, is that? Who want to get pregnant, and they come to my practice. And, I find it so difficult to relax these women, because if you say just relax, this puts so much stress on you. So you really, yeah.
And just recently, I treated a woman, and she had adhesions between the sigmoid colon and the iliac fossa, the lateral wall.
Speak up.
No,
Can't hear.
So I just treated a lady, and she had adhesions between the sigmoid colon and the lateral wall of the iliac fossa. So it was holding the sigmoid colon down in that way, and you could feel that. You could feel it. It was just like a pull through a sleeve, and it was affecting her bowel motions, thin and ribbony. Didn't have a full bowel motion. And she'd had a hysterectomy, but had bled a lot, right, abdominally and the scarring, and so this wasn't endometriosis related, but it worked on her, but it also used seroteptase, the silkworm enzyme. Because this, in our practice, we found that this has quite a beneficial effect on breaking down collagen, it certainly had changed.
You gave it orally?
Yeah, quite a high dosage at first, and certainly this signified changes over a 2 or 3 month intensive course of treatment. She's since gone back to Middle Eastern countries, but her bowel motions improved, and she didn't feel like that same for. I don't know whether that's got any relevance with being used with endometrial adhesions, but certainly it's something that we find in our practice is a useful adjunct as well.
I find that a very interesting.
Okay. Let's move on.
Yeah. I'm a little bit nervous about my practicals because I forgot my. Thank you for your attention. I forgot my paper where I actually explained why every technique should work, and I really wrote it at home the last days, and I left it at home. So I hope I remember.
Intuitive when you work, so you can be intuitive now.
Not in front of all of them. Intuition left me. So as we all know, and you probably as much as I do or even better, we have to do an anamnesis with every client, we have to do a differential diagnosis and a general physical examination. And now there's going to be 5 gentle techniques. They are very general, and I really picked them because from my intuition, I had the feeling these techniques with every woman with endometriosis, one of them at least might work. Or you can address that without creating any more agitation. Because really, as I said, it's really quite something to touch a belly of a woman with endometriosis. Yeah. So these techniques have a good adoption even with women with pain. And but I saw that with your practicals this morning, you are all very good in that dialogue. You know, for each technique, find a balance between afference and efference. So that means giving and receiving. Also, always check with the tissue. You know, always receive information and try to really find a balance there. And every technique should be long and deep and slow. And I saw Michaela did that so great. I was really impressed by the calmness you had. And remember what Sheila said, once the hands are on the body is on command. So there will be one technique on the liver, one on the thoracolumbar junction, one from dorsal and one from ventral. The dorsal one I will not, I just will show, we don't have to practice that one. The radix mesentery, I found a nice technique for that one, and that's what Caroline Stone recommended. And the lamina of Del you say like that? That's the sacral, no, the tubo-vesico-utero ligament. One technique of the fossa issue-rectalis, because I actually noticed, you know, I never did an internal technique on women with endometriosis, but I noticed fossa issue-rectalis was actually quite nice for them because you could reach their pelvic on their pelvic floor, and they didn't have pain. Actually, they didn't mind that one. And then you can end each session with your favorite technique called the pituitary gland, but this will also not do, we will not have time for that. But what I mean with that, think of something very basic for the pituitary gland. You can do some neurolymphatic points, Chapman points, you know, one for the adeno pituitary gland, or for the front one is in front of the mastoid, and one back one on the back of the mastoid, and you can do very little massage in circles. That's a very safe one. You can do a technique on the sphenoid. I saw someone once doing a recoil technique, taking the maxilla and the frontalis and really try to go into the tissue and then do the recoil. So everyone can do that at home. So congestion of the liver, hilus, do you say hilus? Hilus. That's from Baral, this technique. Yeah, you just do that and then we can see how we go.